We're going to briefly talk about the other psychotic disorders that are similar to schizophrenia and share some similar characteristics. Historically, several things happen. Some psychiatrists began to note patients that had some kind of mixed features of schizophrenia and mood disorders, and they termed that the terminology schizoaffective disorder in the 1930s. These individuals have symptoms of both schizophrenia and a mood disorder. Um, and they began to classify people that way going forward. Um, schizoaffective disorder combines symptoms of schizophrenia and mood disorders, specifically bipolar or depression disorder. There's a really low lifetime prevalence of less than 1%. Um, and the bipolar type occurs equally in men and women, whereas the depressive type of schizoaffective disorder um, is more prominent in females. Um, the depressive type of illness with schizoaffective is more common in older individuals, while bipolar is more common in younger individuals. Just as with schizophrenia, women can have a later age of onset um, than do men. The men who have this disorder are more likely to be antisocial. Um, they are more likely to be very flat or have inappropriate emotional affect. Um, Women also have a higher rate of the depressive type of this disorder. So we don't really know what causes this. We know just as with schizophrenia that there's genetic factors do play a role. Um, they found different neurobiological differences in the brain within the neurotransmitter systems, just as with schizophrenia. Um, Also, family history is an important factor as well. The diagnostic criteria um, key is that this person is experiencing a major mood disorder, either depression or bipolar, at the same time as having some symptoms of schizophrenia. They have to have had delusions or hallucinations for at least 2 weeks. However, without having the mood disorder during the course of this illness, which is a little different from having bipolar disorder or major depressive disorder with psychotic features. They have the psychotic features while experiencing the mood disorder, but they also have a period of time when they have psychotic features without the mood disorder. Um, the mood episode symptoms are, present for the majority of the time, however, and you can attribute it to another substance or medical condition. Again, two main subtypes are bipolar and depressive disorder. People with bipolar will also have all the symptoms of bipolar. Um, with the bipolar type. They'll have manic episodes, depressive episodes. Their mood fluctuations are very similar to what you see in bipolar disorder, but again, they're combined with those symptoms of schizophrenia. The depressive type has major depressive disorder, but no mania. This is much more common in women. And then again, they will also have schizophrenic symptoms with it. When you're classifying them, you do classify them in the DSM-5 according to, this is the first episode, or multiple episodes, or this is a continual problem. That's your specifiers within the DSM-5. A differential diagnosis to look at, it's a very complex disorder. So a good medical workup is really important to make sure there's no underlying medical conditions that could be contributing to these psychotic symptoms. Even if they have major depressive disorder, bipolar disorder, is there any medical things that is pushing them into psychosis? You want to rule those out. You definitely want to do urine drug screens to see if these are caused by a substance or some kind of intoxication. Seizure disorders can contribute to this. There's temporal lobe epilepsy, which can present with psychotic symptoms. So this also needs to be ruled out. It's really important to distinguish this from straight bipolar disorder as the treatment is different. Um, this disorder generally has a better prognosis than schizophrenia, but not as good a prognosis as mood disorder. So it falls somewhere in between. Um, Many people have it, but they don't really deteriorate, but they just kind of stay that way. Um, and it's going to be, the how the outcome is really influenced by whether they predominantly have an affective disorder versus predominantly have psychosis. So the more it leans toward more affective disorder, the better the outcome. Treatment adherence, as with schizophrenia, is a strong predictor of a positive outcome, along with social support systems and early intervention. They do require close monitoring and a full comprehensive treatment program, just as someone with schizophrenia does. Of course, pharmacological treatment is really important. Mood stabilizers, such as lithium or some of the anti-seizure medications, are kind of foundational treatments along with antipsychotics. Antidepressants may also be used to treat their depressive symptoms. But you have to make sure that you're dealing with someone who has the depressive type versus the bipolar type. Family therapy is important, helping the family to understand the nature of the illness, the needs a particular patient has, how to interact with a patient. Social skills training is also important, just as it is with patients with schizophrenia, where they can improve that interpersonal functioning and make sure they're integrated into the community. Cognitive rehabilitation also is important. So you use some of the same treatment as you do for schizophrenia. Oops. Another disorder is phreniform disorder. This is a condition with symptoms similar to schizophrenia, but the difference is that the duration is much shorter, lasting only 1 to 6 months. And usually after the symptoms resolve, the person typically returns to their baseline level of functioning. This was first coined by a Norwegian psychiatrist who noted it. Schizophreniform disorder is less common than full-blown schizophrenia and occurs in less than half as many people. Only a prevalence rate of only 0.09% in the general population. But the lifeline rate is a little higher than 0.11%. One key finding is the significant gender differences. The rate of a schizophreniform disorder is about 5 times higher in men than in women. So this one kind of suggests that there are important biological or maybe some socio-cultural factors or stressors that contribute to the higher incidence in the male population. When you look at, again, when they examine the causes, um, there's multiple potential causes, just as with schizophrenia. Um, they have found some brain imaging has found activation deficits in part of the prefrontal region and the striatal activity suppression as well. They've seen some enlargement in the cerebral ventricles. And some differences in electroactivity have been observed as well. So very similar to schizophrenia, but just a very shorter duration. The diagnostic criteria is two or more of your psychotic symptoms, and lasting between 1 and 6 months. Those psychotic symptoms are the same ones as for schizophrenia, delusions, hallucinations, disorganized speech and behavior, and negative symptoms. You have to rule out other conditions that have psychotic features as well. Of course, it can't be attributable to any substances or medical condition. Um, it shares many similarities with schizophrenia, but it's shorter in duration. Hospitalization is often necessary to get the patient assessed, get them initiated on treatment to keep them safe during that first acute phase. Antipsychotic medicines are the primary treatment, but they do respond quicker if they have schizophreniform than do people with full-blown schizophrenia. Around 75% of these patients respond within 8 days. Psychotherapy can help patients to kind of look at what happened, and integrate that into their life experiences. Um, for those who come in with catatonic or depressed features, sometimes ECT is part of their treatment plan. A delusional disorder is a mental health condition that's characterized by persistent fixed false beliefs that are not in keeping with reality. They're typically more non-bizarre delusions, things that could happen, but they're not true. Like, I'm going to be the president of the United States, or I'm going to I'm a famous actor, but they're not true. So they're not bizarre, but they're unreal. Their overall functioning behavior, absent the delusions, is fairly normal. Um, and they are functional and they don't have other psychotic symptoms. This occurs in about 0.2 to 0.3% of people in the United States. It's fairly uncommon as compared with other mental health disorders like schizophrenia or mood disorders. This typically appears in middle age with a mean onset around 40. So that's something really different about it. Um, there's several types, and you'll notice these types of delusions are the same as the types of delusions experienced in schizophrenia. But just again, with no, they're not as bizarre, and there's not other psychotic symptoms. Um, the most common type is persecutory delusional disorder, where the person believes that they're being persecuted, people are out to get them, people are harming them. Other types include the erotomatic belief that someone's in love with them who is not. Um, the grandiosity, where they think they're special, they're famous, they're smarter, it can be a lot of different things. And then the jealous one, where there's belief that someone's being unfaithful to them. And the somatic, where they have delusions about their body and their bodily disorders. Diagnostic criteria, they have to persist for at least 1 month, these non-bizarre delusions. Again, the person remains functional, they're not markedly impaired. Um, they don't have hallucinations, or they're not prominent. Um, and their mood episodes are kind of brief. They're not long. Treatment involves kind of a two-pronged approach, both psychotherapy and medication. In psychotherapy, the key is to establish trust with the patient without directly challenging their delusional beliefs. We don't agree with them, but we also avoid confronting them head on. Instead, the focus is on addressing the distress and functional impairment caused by the delusions. Um, they do better with individual therapy than group therapy. Antipsychotics are first line treatment for this, and you should always start low dose and increase very slowly because they don't have full blown psychosis, and we want to minimize any side effects. If they do have somatic delusions, um, one medication, pimozide, may be particularly effective for those individuals. Then we have lastly brief psychotic disorder. This is when someone has psychotic symptoms that last from 1 day to less than 1 month and they return to normal functioning. Um, there's three main subtypes, either with a marked stressor, something traumatic, something big happened that triggered this, without a stressor, or the postpartum type. Prognosis is generally good with the 50 to 80% of people not experiencing any further major psychiatric problems and returning to their previous level of functioning. These do come on rapidly, and they resolve rapidly. So early treatment is really important um, with these individuals. Um, they're characterized by a sudden onset of hallucinations, delusions, being very emotionally labile, and having disorganized behavior. These symptoms begin rapidly, progress quickly, but they usually recover within 2 to 4 weeks. They usually don't have much prodromal symptoms. Um, and they require brief hospitalization for stabilization in the beginning. They're treated with short-term antipsychotic medication along with psychotherapy to help them process what was the triggering event. Um, Risk factors include a pre-existing personality disorder, a family history, or a severe stress. Our prognostic indicators um, is, but these psychotic episodes are rare but serious, and they involve a sudden onset of psychotic symptoms and often response to a very stressful life event. The good news is that with prompt, appropriate treatment, the prognosis for recovery is really good, up to 80%. Patients who have good functioning prior to the episode and there's an identifiable stressor, they have a better prognosis. If they have some affective symptoms, they don't have any relatives with schizophrenia, and there's a relatively short duration. These all lend itself to a better prognosis. Um, In terms of treatment, again, the pharmacological treatment involves low dose, second generation antipsychotics. And sometimes in the beginning, if they're very agitated, benzodiazepines. It's really important that once the psychosis has resolved, to taper the medications and get them off of them. Some of the psychosocial interventions include supportive psychotherapy, family, stress management, and crisis intervention. It's really important that they're followed up with to make sure that there's no relapse or reoccurrence of psychosis. We also have substance-induced psychotic disorder. This is when you have psychosis relative to some kind of substance. Alcohol, hallucinogenics, amphetamines, cocaine, cannabis, and PCP are some of the ones that you'll see this with. So that's why whenever someone presents with psychosis, we always rule this out. And then we have catatonia. Catatonia is really more of a syndrome, and it occurs in various psychiatric and medical conditions as well. The key features are, either motor inability or excessive activity, extreme negativism where they don't respond to you asking them to do anything or asking them questions. They may be mute. They may have peculiar voluntary movements. They can exhibit echolalia or echopraxia. They may grimace, they may have repetitive movements, they may have odd mannerisms or posturing, which we call catalepsy, where they hold a certain posture for a long time, or the waxy flexibility when you can move them. Um, it can again occur in a range of different conditions, um, but it does require prompt treatment. There's a rating scale to assess the severity of catatonia. Lorazepam can produce a dramatic improvement in these catatonic symptoms within minutes when used as, as a trial. For refractory cases where benzodiazepines fail, ECT therapy has shown to be 80 to 100% effective. It can lead to serious medical complications like DVTs, pressure ulcers, malnutrition, aspiration because of the lack of movement. Malignant catatonia is a life-threatening variant characterized by autonomic instability. They may have fever, rigidity, require immediate intensive intervention. And that's all for that.